Are you letting them income?
Yes.
Before we start the video, let's just get in a few people before we start the video.
For over 20 years, Clinics Health Group has provided world-class healthcare to underserviced communities. With every new facility we open, quality, affordability, and excellence is what we've become synonymous with. To that end, Cullinan Wellness Hospital is the latest addition to the group and the third in our growing roster of psychiatric care services. Located in Cullinan, east of Pretoria, our state-of-the-art facility is perfectly suited to service patients as far as Mpumalanga, Limpopo, and the Northwest Province in a tranquil setting surrounded by a luscious garden and mountain views.
It's very important for us to have such facilities in our communities because previously we've ignored the psychological instability. We thought we can go on with stress or depression, and because now that we have come out as psychiatric faculty to say we can offer this kind of care, treatment and rehabilitation for people who are in need of, who needs to heal emotionally or psychologically. So these kind of facilities are important to be. I would wish that every area would have this kind of wellness facilities.
I think mental health institutions and wellness centers such as this one are important mainly because we live a very rat race type of life and struggle to see when we are truly struggling with life. And being able to come into a facility like this allows one to pause and acknowledge whatever is happening in your life that is bringing you down, pause and regain function, pause and get back onto your feet in a way that you didn't even realize you needed. There's the need to have an out of your comfort zone area that will move and shake you as much as possible to get you back into a better state of you.
No matter the treatment or duration of stay at Cullinan Wellness Hospital, our patients and their loved ones can rest assured that they will be taken care of and watched over by our team of experienced mental health nurses, psychiatrists, and clinical psychologists.
Most of the patients that we admit are voluntary patients and they come on their own. The diagnosis that we normally work around is that patients with bipolar mood disorder, major depressive disorders, as well as post-traumatic stress disorders. Some has personality disorders such as gambling.
Our hospital provides private psychiatric services that aim to help the individual experience the fullness of life. We cater for a wide range of patients, including those with depression, bipolar, post-traumatic stress disorders, anxiety disorders, sleeping difficulties, neurocognitive disorders, dementia, and psychiatric conditions, amongst others.
My approach is I use what we call cognitive behavioral therapy, CBT. So basically it's helping because most of the time I've noticed that we tend to be depressed or go into mental problems because of the channeling of our thoughts. We tend to think, if you are going through a difficult situation, you tend to think more negative about it than thinking positive about it and actually getting a solution. So I just help my patients to come up with solutions, and hence I use solution-focused therapy, because I'm confident that they do have solutions. It's just that sometimes they're not confident to put them into action.
My approach when treating a patient goes back to the good old Batupele principles. We follow a very client-centered approach. Every case is different, and so applying Batupele principles where it's about the patient, it's about dignity, it's about ensuring that the patient's needs are met, is at the core of practice, is at the core of all intervention.
As mental health practitioners, we encourage individuals to visit our facility so we can assist them in finding routine solutions to the problems they face on a day-to-day basis.
I think from a very simple point of a non-functional mind is a non-functional human, and neglecting mental health means, in essence, neglecting a whole part of yourself that is very necessary to maintain function on a day-to-day. The more we ignore the brain and the psychology and the emotions of a person as we have been, the more we are likely to not reach to the full potential that we could.
At Clinics Cullinan Wellness Hospital, we believe mental health is the cornerstone to helping you find and lead a happy, balanced life. Visit our magnificent facility at Hospital Road, Cullinan, Pretoria East. We're open 7 days a week and are ready to receive you.
Good evening, colleagues, and welcome once more to our weekly webinars brought to you by Clinics Health Group. And we're excited once more to be with you this evening to share thoughts on various topics. And tonight we're going back to vaccines and also to share about what is currently happening in our country in terms of public health issues. And before I introduce the first speaker, I was going to be introducing the next speaker. She'll just do a short introduction about the main speaker. Try just to indicate that these webinars are CPD accredited, and we, as a reminder, please do make sure that you give us your full details, including your registration number, if you're with the HPSSA or the Nursing Council or the Pharmacy Council, the Allied Health Council, so that we can submit that information on your behalf. Those who are with the HPSSA, you should note that or know that you don't need to do anything once you've given us all the information. We'll send it to the HPSSA through our group. They will support us, who will then upload it on the HPSSA website, and you get your CPD points, and they'll send you a notice to say that your points have been registered. And also note that these meetings, so those presentations are recorded live on YouTube. If you want to go back and see what the presentation, something that you missed that you need to refresh your mind, you can always look back and go back to YouTube. For you to get reminders about this meeting, so we ask that you go to YouTube and like us on YouTube, like Clinics webinars, and you get all these reminders, and you'll always be able to access previous presentations on YouTube. This evening we are partnering. Last but one is that as a reminder, always make sure that you mute yourselves and switch off your videos, just to enhance the quality of the reception, the link. As we know that we are now beset with load shedding, it has come to be part of our lives, and I'm so glad that we are able to link up with us. I don't know if you're all connected on using your other means of connection, if you're on load shedding or not, but we appreciate your presence this evening. I'm going to ask to introduce Dr. Kerrigan McCarthy, who's a medical advisor at MSD Pharmaceuticals. We work together with them to make sure that we have this presentation. Also to send a message to all colleagues who are connected here. If you are working for any pharmaceutical company and you've got access to speakers of different disciplines, please do get in touch with us, and we don't hesitate to work with colleagues in the health field broadly. We've not only pharmaceutical companies, but also other entities in the healthcare industry. I know that we've got other colleagues who are working in the healthcare industry other than the healthcare groups and pharmaceutical companies. And so we are also inviting you to partner with us. And if you have a speaker that you reckon that will benefit if we invite them to speak to us, please contact us at clinics@webinars.co.za or just contact me directly at rbila@clinics.co.za. Then I was weird to just unmute yourself and switch on a video and do the introduction of the speaker so that we move on and continue with our presentation this evening. Welcome, Vuyo, and thanks for organizing Dr. Kerrigan McCarthy for tonight.
Thank you so much, Dr. Mila. Hi, everyone. So as I have been introduced, I'm Dr. Thanokazi Kaqana. So my role is to just introduce our speaker today. And I thank both the speaker and the Clinics Health Group for giving us an opportunity to have a presentation on this very important topic today of measles outbreak and vaccine confidence. So Dr. Kerrigan McCarthy is a pathologist at the National Institute for Communicable Diseases. She's under their Center of Vaccines and Immunology, and she has decades of experience in support of outbreaks and outbreak investigations and management. Currently, she is responsible for a couple of viral diseases, which are measles, rubella, and polio. So she's responsible for the surveillance of those diseases and the development of water-based epidemiological surveillance for SARS-CoV-2 and other vaccine-preventable diseases. I thought that it would be fitting to have someone who is working in the preventable disease space and who is also experienced when it comes to outbreak investigations and management. She's also quite very influential. She is part of some departments of health and bodies. So with no further ado, I would like to introduce Dr. McCarthy, and I hope we have a great day today.
Thank you for the introduction, colleagues, Thanokazi and Ray. It's lovely to be with the clinic group today, and I'm very glad to be joining your team to share what is very topical and very important today. I'm going to share my screen now and put up my PowerPoint presentation. I'd just like to confirm that folk can see.
Yes, Doc.
Great.
Thank you.
So I'm going to be sharing a little bit about the current measles outbreak and looking a little bit at some of the contributory factors. I have to share that, as Dr. Sandra said, I am a pathologist and I'm not a social scientist. And so the perspectives that I give on things like vaccine confidence are really the tip of the iceberg and are more adequately dealt with by folk such as Charles Wasonge and the group from the MRC in South Africa, who have looked into and are extensively researching vaccine confidence in our local setting. So I will start off by talking about measles globally and locally. We'll then talk about some diagnosis and case management. We'll move to root cause analysis, how to prevent measles. We'll look at missed opportunities for vaccination in South Africa. And lastly, we'll end off with what can I, as a clinician, you as clinicians in the field at the coalface, do to contribute to measles prevention and elimination in our context today. So globally, reported measles cases have declined an incredible amount since 1990, from around 18 million per year to around 12 million in 2019. Of course, these figures represent cases that are reported to the World Health Organization, and so they're likely to be far in excess of that. And surveillance is likely to have increased in accuracy over this time period. So the 12 million probably more accurately reflects the actual number of cases of measles globally than the 80 million in 1990. The point is that the case numbers have decreased. And when this report looked at the age standardized incidence rate, it has decreased around 6% per year, from a total of 1,200 cases per 100,000 population in 1990 to just under 200 cases per 100,000 in 2019. However, despite this, there still exists a 100-fold difference in the age standardized incidence rate of measles between the wealthy and the poorer countries, with wealthier countries having a 10-log reduction or 10-fold reduction in the incidence of measles per 100,000 cases compared with the poorer countries. And this is beautifully reflected in this graph showing the global total in red, from around 8 million to present total 2019 of just under 2 million, with the different socio-demographic indicator regions having corresponding reductions. So why has there been this concerted reduction? Well, that is because since the 1990s, the World Health Organization has been actively focusing on measles reduction and measles elimination as an intense, focused, intentional strategy. So it's no accident that measles has decreased in this way. And the current iteration of the World Health Organization strategies is described in the Measles and Rubella Strategic Framework, which will cover the year 2021 to 2030. The World Health Organization envisages a world free of measles and rubella by 2030. And so the question is, can it be achieved? Theoretically, measles elimination eradication is possible, like smallpox was eradicated, because measles has a single unchangeable serotype, the virus itself. The virus does not have an animal reservoir, unlike SARS-CoV-2, and so it cannot be reintroduced into the human population. And an effective vaccine is easily manufactured and is available and safe. Measles virus does not mutate like SARS-CoV-2. And so that means that if we continue using the vaccine in a strategic and informed and comprehensive and accessible way, it's possible to eliminate measles from the world. So how has this strategy been progressing? Well, the world was on track in 2018. And 2019, we saw some enormous numbers of cases in the region of 100,000 per month, particularly emerging from the WHO Afro region. But as 2020 and 2021 progressed, we saw fewer and fewer cases. However, we have seen a slight resurgence of these cases in 2022, and the big question is why? And the reasons behind this include a growing sense of vaccine hesitancy, probably fueled through the COVID vaccination misinformation or infodemic. Of course, global transmission through air travel and trade has occurred. And there have been COVID-related disruptions of routine and supplementary immunization campaigns. And in our country particularly, we are living with a legacy of low vaccination coverage in older age groups, which are then vulnerable when the virus is reintroduced. What's been happening on our South African landscape? Well, we've had big measles outbreaks in the mid-1990s. In the early 2000s, 2003 and 4, we had over 2,000 cases. And then a massive measles outbreak in 2009 to 11, where we had over 20,000 laboratory confirmed cases. Of course, there were probably more than 10 times that amount. And then in 2017, there was a very small outbreak of fewer than 300 cases. And in between these larger outbreaks, there have been sporadic cases that have occurred through the years, which have been effectively contained through ring vaccination and because the population has been adequately immunized. So while there is a trend towards reduction in measles cases in South Africa, our current outbreak is worrisome with regard to the elimination agenda. The NICD releases a situation report every Wednesday. It usually comes out and is distributed on Thursday. And this graph is from yesterday's report, and it shows on two axes with a histogram and a line diagram, a line chart. Firstly, the number of cases that have been, number of samples that have been submitted for testing, that's the light green line, and the number of positive samples, the dark green line, by epidemiological week of 2022 and now 2023. The red line can be interpreted on the right vertical axis, and that is the percentage positivity rate amongst cases submitted. And you'll see that the percentage positivity started increasing towards the end of the year and decreased in the early weeks of 2023. The reason for this increase and then decrease is most likely related to reduced health seeking by parents and caregivers over the festive season and New Year. But you can see the case numbers again and the testing numbers started increasing again from week 3, 2023. As you well know, our current outbreak began in Limpopo, most likely through importation of cases from north of our borders. From 2015 to 2019, there was an outbreak raging in the DRC. And then in August of last year until October, there was a large outbreak of measles in Zimbabwe. So the appearance of a few cases in Limpopo in late October triggered alarm bells, and a vaccination campaign was started in the under 5 category shortly thereafter. However, it was insufficient to contain the outbreak, and cases have spread to other provinces, including Mpumalanga, Northwest, Gauteng, and Free State. And most recently, you'll see in this week's situation report, the Western Cape has formally declared an outbreak as they have crossed the threshold of cases for a definition of an outbreak. That is 3 cases in a calendar month in a single health district, with 4 cases being identified in the City of Cape Town municipal area. So this is an epidemiological curve. It shows the epidemiological week of the year on the horizontal axis. It shows the number of cases of laboratory confirmed measles, and the different colors represent the different provinces. The diagram is annotated to show when the outbreak was reported or declared in the given provinces, and the most recent addition will be seen on next week's diagram when in week 7 we declare the outbreak in the Western Cape. What you'll notice is that all of the provinces have a sort of biphasic shape, with an increase prior to December, a decrease over the festive season, and then a subsequent increase as the schools have gone back. So what is the cause of this measles outbreak? Well, it helps to have a little bit of virology and vaccinology as a background. Essentially, the measles virus is a single serotype that comprises a number of proteins, 6 structural proteins and 2 non-structural proteins. And these proteins confer upon the organism the ability to attach to any particular cells in the respiratory tract that carry the CD147 receptor, and to bind and to enter. And then once entering the respiratory tract, there is a dissemination through the entire body and the emergence of antibodies that confer lifelong immunity. The wonderful thing about the way the measles virus attaches is that it attaches through a N protein, and the N protein is unchangeable. So, no, sorry, not the N protein, the hemagglutinin protein, the H protein. And it is unlike SARS-CoV-2, so it doesn't mutate. And so we don't have the scenario of a changing spike protein or equivalent in measles. And this means that the antibodies elicited by the vaccine are are protective. The measles vaccine, in fact, was invented in the 1960s. It is actually based on the wild-type measles vaccine, in other words, the measles vaccine that causes infection in humans. And it was passaged multiple times in cell culture and then lost its virulence. And so when it is injected into the body, it causes a measles infection. And the immune responses to this vaccine strain are identical to the immune responses caused by natural infection. And so therefore, this vaccine elicits a robust production of IgM and IgG. And because the measles vaccine does not change, it confers lifelong immunity. So if we have a look at this diagram over here, this is a diagram of the antibody responses that are produced by the human body following measles vaccination. If measles vaccination happened on day day minus 7 to 10, 7 to 10 days later, there is the production of IgM to the vaccine strain, and then IgG, which is the blue dotted line. And when the IgG levels are high, they remain at certain thresholds for lifelong and confer lifelong immunity to measles virus. So it stands to reason then logically that the greatest risk factor for acquiring measles is failure to vaccinate. And we can see this in a number of ways in the current outbreak in South Africa. Firstly, we have to look at the vaccination coverage in the previous 2 years. And we can see that in December 2020 versus December 2021, the measles vaccination coverage for MCV1, that stands for measles containing vaccine 1, that's the dose given at 6 months, was as low as 34% in some provinces in Limpopo, as low as 53% in the Northern Cape, and in the 60s for Northwest Province. Some provinces appeared to achieve high vaccination coverage. And then the following year, December 2021, there was some improvement in some provinces and a decrease in other provinces. But across both vaccines, that's the measles containing vaccine 1 and 2, no province achieved anywhere near the required vaccination coverage in order to prevent outbreaks, and that is 95%. So if one considers the actual numbers of patients, for example, if we have 100,000 children in South Africa and we have a vaccination coverage of 72%, that means we have around 28% of children who are unvaccinated, and that equates to 28,000 children. And that's a lot of children who don't have a measles vaccine and are therefore not protected against measles. The second piece of evidence that tells us that one of the reasons for this outbreak is low vaccination coverage is the what's called the AR, the attack rate by age group. So this is a table that you'll find in our situation report. It has data for each province where there is an outbreak: Free State, Gauteng, Limpopo. And in each of these columns, there is the number of cases and the age-specific attack rate. The attack rate is the number of cases divided by the estimated population size over this year or last year in that particular province. And we've divided the population into a number of age groups. So it's the under 1 year, the 1 to 4, the 5 to 9, the 10 to 14. And you can see immediately that the greatest number of cases is in the 5 to 9 year age group, followed by the 1 to 4 year age group, and then the 10 to 14 year old age group. And if we look at the age specific attack rates, we can see that just under 8 children per 100,000 children are developing measles across the provinces in South Africa. But if you look at the age specific attack rates, you'll notice that they differ by province. And there's two reasons for the fact that they differ. Number one, the outbreak has been around for longer and there are more cases in Northwest than there are in Gauteng, for example. And number two, because there are fewer children in Northwest Province than there are in Gauteng in each given age group. So the age-specific attack rate is higher in Northwest than it is in Gauteng. But what this does tell us is that there is a significant immunity gap in the population. there are children who have not received the measles vaccine. And we can see that not only have the less than 1 years not received the vaccine, but a significant number of children who are in the year 10 to 14 year age group have also not received the measles vaccine. And this tells us that we're not dealing with a problem that was created from COVID, which occurred in 2020 to 2021. We're looking at a problem going back as far as 2013, 2014, 2015. Fortunately, some researchers have done some excellent evaluations of our South African context to understand the vaccination coverage rates in South Africa. We can calculate vaccination coverage rates from two perspectives. We can look at, firstly, the what we call the administrative coverage. So that's the number of doses that have been administered divided by the theoretical population size. And these numbers are given in blue as a continuous line across the provinces based on DHIS data. We can also determine the vaccination coverage for each province by doing a household survey and looking at road to health cards. And this was done in 2019, led by Dr. Poshmutz-Bedzi. And you can see that the provinces have different thresholds of vaccination coverage as determined by household visits and household survey. What is important is it's usually regarded that the household surveys are more accurate than the estimated administrative coverage, because the administrative coverage uses the estimated population size, whereas the household visits actually count individuals. And so you can see that the different provinces have different coverage rates for the measles second dose vaccine. The other helpful analysis that was done using data from a variety of sources was to look and identify zero-dose children. So these are children who have not received any vaccines. And one of the reasons this is interesting is because these children, if they are exposed to infectious disease, then become a cluster and then a focus of infection, and then transmit the infection to outside of their little cluster. And they can cause significant amplification of the virus and infection rates, and then seed the infection into other communities where there may be vulnerable persons who can't receive vaccines. So this study identified that around 9% of children in 2021 have not received any vaccines in South Africa. And this equates to around 104,000 children. And if we consider that we have a birth cohort of about 1 million every year, this is a relatively large proportion of children and a large number of children. These children have the highest proportion in Northwest Province, where there is occasionally a zero-dose children prevalence of around 30%. But the absolute numbers of children, which are perhaps more important in this case, who have not received vaccine, is localized in KwaZulu-Natal province. And so these are the zero-dose children are the focus of a number of interventions supported by the UNICEF organization. One of the good things about the 2019 household survey was that they also looked at reasons why people missed measles vaccination specifically. And this pie chart, which is a little bit complicated at first glance, divides the reasons up into a number of categories. Evidence shows that a knowledge deficit, the family did not know that vaccination was required, is the key driver of a quarter of measles vaccination. Failure to vaccinate against measles, but the health system issues such as stock out or inaccessibility of the facility are also reasons, and structural problems related to societal factors such as no one being available to take the child, or the family member wasn't alerted or aware, are reasons why measles vaccine is not given. Interestingly enough, refusal on the grounds of religion or other accounts for less than 4% of the failure to vaccinate in the survey that was done in 2019. An excellent study published by the ASAF group into the root causes of low vaccination coverage and under-immunization in sub-Saharan Africa identified three main themes for the root causes of non-vaccination. The first is knowledge deficiencies and inaccuracies. The second are trust issues. And the third are convenience, access, and reliability. Knowledge deficiencies are relatively easy to intervene and provide knowledge, one could say. However, the vaccine hesitancy movements are driven through misinformation that is made available through social media and is a little bit more pervasively and recalcitrant to having interventions presented to eliminate these sources of knowledge deficiencies or inaccuracies. In terms of trust issues, trust in the healthcare system overall impacts on engagement with health services. And so if people have bad healthcare services in one particular area, it tends to impact negatively on other areas, including vaccination. Of course, social-cultural drivers of culture and religion impact significantly on vaccine uptake because they speak to individual and communities' worldviews around health and illness. And these worldviews may not be amenable to interventions such as vaccines. Convenience, access, and reliability, including physical barriers and poor service delivery, are key drivers in underlying under-immunization or low vaccination coverage in South Africa. So what about vaccine confidence? Well, it's important to define, firstly, vaccine confidence and its opposite, vaccine hesitancy. The Strategic Advisory Group of the World Health Organization convened a working group on vaccine hesitancy. And this group defined vaccine hesitancy as a reluctance to accept immunization that is complex and context specific, that varies over time and place, and is vaccine specific. More simply, it can be said that vaccine hesitancy is an attitude of ambivalence towards vaccine. We have, in years gone by, been trained as healthcare providers in the knowledge deficit model. That is, that we have understood the problem of reluctance to take vaccines as a deficiency in knowledge, and that we can solve the problem by providing more knowledge about the vaccine or the vaccine side effects. And in today's age, this model it has become largely unhelpful because it doesn't address the factors that influence parental and caregiver acceptance. A lovely Cochrane review has been published, and if you have time to read it, it's worthwhile, but there is a short summary in the SAMJ that defines or nicely categorizes the findings about vaccine confidence in South Africa into two groups. Firstly, those who hold to a neoliberal logic, and that is that the health and healthcare decisions are a matter of individual risk and choice and responsibility. And the second group, that of social exclusion, where particular groups feel that the powers that be do not see them, and they feel marginalized at a number of levels, one or more, namely economic, political, or cultural reasons. And this social exclusion in turn lays the foundation for distrust, alienation, and resentment, and therefore leading on to non-acceptance of vaccines. So with that in mind, I would like to move on to the question, what can I do if I have a suspected measles case? Well, the first is to provide appropriate, supportive, diagnostic, and preventive care. And I'm going to use a case study to talk through these issues. This is a case that came through to our laboratory. It was a 14-month-old infant who presented in November 2021 to the emergency department of a district hospital in the Western Cape province. The little one and their family had recently arrived from the DRC within the last 28 days. And mom reported that the child had been febrile for 2 or 3 days prior, had had red eyes and cough and then also commenced on the day of presentation at the hospital with a rash. And in fact, the rash was the precipitating cause for why mom took the little one to hospital. The clinician suspected measles and sent off a specimen of blood and another specimen of urine to the NICD for testing. And when we received the sample, the specimen was PCR positive for measles in the urine. In other words, we found measles RNA in the virus in the urine. And we sequenced it, and we were able to identify that it had a lineage that was identical to strains circulating in the DRC and Zambia in recent years. The sample was also IgM positive for measles, indicating that that the body had started producing antibodies against the measles virus. So classically, measles begins with malaise, respiratory symptoms, including cough and coryza, together with fever, anorexia, and conjunctivitis. The rash usually starts on day 4 of the infectious period, but the incubation period is day 9 to 14 days. We count the day of rash appearance as day 1 of the illness, and the preceding symptoms of fever and malaise as the prodromal illness. The rash usually starts on the face and then progresses on the extremities to include the palms and the soles, and it may become confluent as on the chest as the inflamed areas progress. It's not usually itchy, but it does heal with a desquamation, except on the palms of the soles. And on the day that the rash appears, the patient is usually at the worst point of their illness from a symptomatic perspective. Children with who have not been vaccinated and who get measles may, during the course of their illness, develop diarrhea. They may develop pneumonia. Otitis media is also common. Very rarely, about 1 in 1,000 cases, develop a headache and sometimes altered level of consciousness and seizures as part of an encephalitis syndrome. Mortality from measles is rare in children over the age of 1 year and who are otherwise healthy, but can be as high as 20% in malnourished infants or infants with advanced untreated HIV infection. So here are some photographs of the measles rash. Clinicians classically report the presence of Koplik spots, that's a rash on the buccal mucosa, but this is not considered to be pathognomonic or uniquely associated with measles, but it is a helpful sign that measles may be present. The differential diagnosis for fever and a maculopapular rash is broad and includes rubella, scarlet fever, human herpes virus 6 and 7, meningococcemia, parvovirus B19, and cytomegalovirus. And for this reason, the diagnosis of measles must be made through laboratory testing. The type of tests that are done are serology, where we look for antibodies, and typically we look for IgM antibodies to signify acute infection, and PCR when we detect measles RNA, indicating that the virus is actively replicating in the tissues. The interpretation of these tests depend upon the type of sample, the type of test done, and the timing of collection of the sample relative to rash onset. So if in our little chap who came from the DRC who presented on the day of rash, we can look at this schematic graph over here at the green line, and the green line is the day of onset of the rash and is considered day 1 of illness. And at this green line, we can see that the purple line over here, which represents IgM antibodies, is very low. We can also see that this solid line over here is virus detection in oral fluid, and the dotted line is virus detection in dried blood spot. And we can see that the virus is replicating and at high levels in oral fluid and in the blood. So a blood test taken at this time point is likely to be negative for IgM, but very likely to be positive for PCR. However, if the little one had come to the hospital on day 3 after the rash, the story would be slightly different. The IgM would highly likely be positive, and the virus in blood would have tailed off a little. And so the PCR on blood may well be negative. So these are important to help us guide our interpretation of the diagnostic testing. What will we do for a case of measles? We'll treat them symptomatically with fever and manage hydration levels so as to prevent dehydration. All measles cases should be given vitamin A, as vitamin A deficiency is associated with a higher mortality. And if a secondary infection is present, such as a pneumonia or an otitis media, we'll provide treatment with antibiotics. It has been shown that children who do not have pneumonia or otitis media will not benefit from prophylactic antibiotics. So we would only treat these if these signs and symptoms were present. Who is at risk? Who should we watch more closely? All adults who develop measles tend to have a severe course of infection, although they may or may not have complications. Children who have measles who are under the age of 6 months may have a worse infection. And any child or person of any age who is immunocompromised due to a cell-mediated immune deficiency or has TB co-infection has a higher risk of complications. So if these complications are present, or if the person has underlying risk factors, we should admit these children and all adults and watch. A recent review did a modeling exercise and looked at the various contributions of certain underlying factors, child stunting, being underweight and wasting, and vitamin A deficiency are the 4 largest contributors to measles mortality globally. And a very helpful article that was published during the 2009 to 2011 measles outbreak in South Africa from the Red Cross Children's Hospital nicely looked at the risk factors in our context. Essentially, a child who has a lower weight for age score, in other words, they are either stunted, underweight, or malnourished, has a significantly greater risk of death. And females, for a reason I can't explain, in this cohort had a greater risk of death. And children who were HIV infected had an enormous 7 times risk of death, 7 times greater risk of death compared with HIV uninfected children. Of course, all of these certainly being malnourished and HIV infection are preventable in the context of children, and these speak to the underlying societal factors that predispose us not only to low vaccination coverage rates, but also to more severe measles disease. So what is the second thing that we should do after we've provided appropriate supportive and preventive care? We should be familiar with the case definitions for suspected measles cases so that we can notify all suspected cases to our district or provincial surveillance officer. This requires completing a paper form or an online form and submitting it to the measles, the notifiable medical conditions surveillance team. And each sample that is submitted when one wants to make the diagnosis, that's a sample of blood or urine or throat swab, should be accompanied by a completed case investigation form. The completed case investigation form is absolutely essential because it gives us important information like the date of onset of the rash and the prior vaccination history and the travel history. And this can help us make the diagnosis better. It can also help us monitor complications and outcome. The public health authorities will investigate the case and conduct ring vaccination, that is contact vaccination of all under 5s and unvaccinated contacts. And this is described in the vaccinator's manual that is currently being rewritten in preparation for or as part of our vaccination campaign that has been rolled out. The last thing that one should do when one is confronted with a suspected measles case is to assess the vaccination status of the child, explore the reasons for non-receipt of vaccine, and address uncertainties. And in keeping with our more nuanced understanding of the drivers of vaccine uptake in parents, we should not adopt a knowledge deficit paradigm, but a more nuanced and less biomedical approach. It's important to have conversations with our patients and their parents to understand their context and their social struggles, to understand the meaning systems and the social groups' understanding of life, death, and illness, and to accept that the forms of rationalizing that we are taught in Western medicine do not always align with our patients' ways of interpreting the world. And if we understand that at the heart of parental decision-making are a number of drivers, including a desire to protect their child's health, and need to be a part of the decision-making process, and need to belong and to feel included, to be confident with expert systems, and to have their priorities recognized, we're immediately on the right track to developing an empathetic, insight-led alliance with our patients that can only support vaccine confidence. So with that, I would like to thank my colleagues at the Center for Vaccines and Immunology, the Department of Health and the World Health Organization for some of the data elements. And lastly, to thank yourselves, clinics, for the work that you do in supporting public health and the health of people, and to thank MSD for creating this opportunity to share with you. I'd be happy to take questions if that's appropriate, but I'm going to hand back to yourselves, Ray and Tando.
Thank you very much, Dr. Kerrigan McCarthy. Well, indeed, it is appropriate to take questions. So my video, I'm on load shedding here, and I'll try to.
Oh dear.
I just used my. In the meantime, if I can just take more questions, colleagues, you quite welcome to post your questions. So just on the chat box, just to indicate you just post your questions, then we can take the question asked to Kathy to answer those questions. Or you can just write on the chat box here. You indicated that COVID was not the primary reason for the same surge that you're seeing in measles vaccination. So you basically said about dating back to about 2015, or so that we've seen these problems. The majority of cases, are they locally based, or you basically indicated one or two cases where we had patients coming in from outside South Africa?
We're very lucky to be able to have these new technologies of genotyping, molecular sequencing of all pathogens. And our sequencing of measles over the years has indicated that by and large, measles is imported into South Africa, and we can determine the origin. So the source has ranged from Europe, where we had a number of cases in 2015 where the index case had a genetic sequence identical to an airport worker in Munich. And then the 2017 outbreak was imported. The strain of measles was imported through some South Africans who went skiing in Europe. And then, of course, the current outbreak is through importation from local, across our border, from Zimbabwe and further north. So, of course, we know that organisms don't need passports to travel, and so they travel where they want to. So we can expect that all diseases, most likely, that are not endemic, are going to be brought in to our country. The key thing is not so much where the virus comes from, but rather, are we protected? We know from COVID, disease somewhere is disease everywhere. And so the question is, we ensure that our vaccination coverage is high enough so that should a virus be imported, that it won't spread.
Thanks a lot for that response. There was a question here that please revise on specimens to collect in suspected cases. Just indicate which are the specimens to collect. I think with this case on the DRC, you indicate that they had taken the specimen from the urine, and also it was a blood specimen. But when you were talking about which specimen you show in the grams, you seem not to include so much about urine specimen. So maybe just indicate which specimens to take to get to reach a diagnosis.
So the standard specimen is a blood sample. However, if the patient presents early on in the course of illness, and you can judge that by the day of onset of the rash, the blood sample might be negative. And so then it's very helpful to submit a blood sample along with another sample that may contain circulating virus. And the two common samples that contain circulating virus or excreted virus are throat swab, like we did for COVID, or a nasopharyngeal swab, or urine. So urine is sometimes easier to obtain. So it's a very simple specimen to submit. So the general rule is always submit a blood sample, but if the patient presents early in the illness and the rash has not yet appeared or has just appeared, it is helpful to have an additional sample to do a PCR testing.
Okay. Yeah, the next question is more related to that, because they want to know whether there is any waiting period, especially if a child, there's a vaccination drive and the child presents with influenza attack and they're pyrexial, and also with urticaria. So the waiting period to do the test, to take the samples.
So I think there are two components to the question. There's the question around, would you vaccinate a child who presents ill with influenza or other non-specific symptoms? And the answer is no. If a child is ill, measles is a live attenuated vaccine, and in other words, the virus and it will replicate in the person, and it's not advisable to give a live attenuated vaccine to someone who has an underlying illness, even if it is acute like influenza. So one would need to then ask the child to return in 2 to 4 weeks until they're better. If a child presents with an illness and you want to know whether you must do diagnostic tests on them, no waiting period. One should perform diagnostic tests immediately on presentation, because the patient's not going to come back. And that begs another question, is that in the case of an outbreak, if we see a person who meets the clinical case definition of measles, should we test? Because we can make a clinical diagnosis, and we can also know that the child is a contact of measles cases, or there are measles cases in the area. So of course this is measles. Why do we need to test? We should test. The reason is that, number one, we are reporting cases to the World Health Organization, and there, as you saw, is a measles elimination agenda. The second reason is that measles cannot be diagnosed clinically, and there is a broad differential diagnosis. And what we have seen and what we're expecting in this outbreak is that we will see the emergence of rubella towards the end of the outbreak. And we need to document that, in fact, rubella cases are occurring for the reason that rubella has an entirely different set of risk factors through causing congenital rubella syndrome. So it is important to send a diagnostic test for measles. Thank you.
Okay, thanks for that, Kerry. The question is, it's probably not only about measles, but just to say, what are the strategies, effective strategies to overcome vaccine hesitancy in general, not only related to measles? I know that you've covered 3 categories generally.
Yes. So thank you for the question, Molefi. Unfortunately, I am a pathologist and I'm trained in Western biomedicine, not in social sciences. So I can only speak from my experience as a clinician in the few years that I was active. And I find the approaches very helpful in terms of developing an alliance with one's patient to find commonalities in terms of an intention to keep one's child well, and to build relationships that may lead to trust and a change in mind. I think it's important to have a longer term vision rather than just the immediate moment that the patient is in front of you when patients are hesitant. People who are hesitant tend to fluctuate in their ambivalence about vaccination, and they may not change their mind on the basis of a single encounter. So developing a trusting, transparent, open, accessible relationship with one's patients, I think is the key to vaccination hesitancy. There's some patients who will never vaccinate, and one doesn't know who those people are and what kind of events may lead to them to change their mind. So I think persistence, commitment, openness, transparency, availability are key aspects of working with vaccine hesitant communities.
Yeah, you indicated that there is a correlation between the health systems, whether it's a poor health system or good health system, that is related to a poor coverage of vaccination. So the two provinces that you've highlighted, they just confirm what we all know about what the situation is like. You mentioned the Northwest, and perhaps Northern Cape is the Eastern Cape, those provinces.
Mm-hmm. I mean, I think it's important to acknowledge that in those provinces, there are also significant structural problems, management problems, health systems, issues that have led to low accessibility of vaccination. One of our students conducted a structured interview with moms or caregivers in the queues at the vaccination stations early in November last year. And one of the biggest reasons for non-vaccination was in the very rural areas where people had to walk 10 kilometers or so to the nearest clinic, was that the clinics often had stock out. So about 60% of people reported not having vaccinated on time because of vaccination stockouts. So these are structural problems that can very easily be addressed, but they're part of a whole health system strengthening approach.
Okay. There's one question on vitamin A, because you said just when every patient who's got measles, they should get vitamin A. And the question is, what are the doses that you need to give? What's the dosage for children?
I'm happy to make my presentation available, but I can share with you, you can Google the essential drug list, and the essential drug list will have the vitamin A dose for children. The dose is lower for those under 6 months, 6 months to 5 years. But I don't want to say the dose because I'm not sure of it. Over from.
Okay, so my internet connection is very low. I've got a weak connection for connectivity. There's a doctor says that they're seeing cases of mumps in children recently, quite a few. Can you hear?
I'm afraid the connection is poor on my side or your side. I'm not sure. I didn't hear the question. Someone could write it in the chat.
For a bit.
Are you back?
Yes. Well, I can still see you, but you've shifted. But I was asking about mums. Can you hear me? Still hear me?
Yes.
Yeah. What about, because this is the doctor said they're seeing a few cases of mumps in children in the last 2 weeks. Do you have any comments on this?
Mumps is not a notifiable medical condition in South Africa, and so from a resource perspective, the NICD has not conducted surveillance for mumps in a systematic way. So we can't comment on the prevalence of mumps in the same way that we can tell you about measles, but we are aware that there are increased numbers of cases in Gauteng. We've had reports from, in fact, across the country of cases of mumps, and a few cases of mumps in encephalitis being diagnosed. So we are aware of this, but we do not do surveillance for mumps in South Africa. Neither is mumps vaccination part of our expanded program of immunization. It is available as part of the measles, mumps, rubella vaccine, but not in the public.
Okay. So not much information that we can glean the same way as we can with measles, because of it being not a notifiable disease. Now, in adults, you mentioned that, when it was interesting to see that even adults can are prone to measles. When I was speaking to some of the colleagues when inviting them to this webinar, and some is, as physicians, we don't see such cases. We leave this to the pediatricians. Adults at risk of being infected with measles, and does it mean that one has to be re-vaccinated at a later stage in adulthood?
So it does happen from time to time that an adult gets to adulthood and is neither vaccinated nor has been exposed to measles. So in our current case, our oldest case of measles is in a 58-year-old male. But by and large, by the time people reach adulthood, they've either been vaccinated or exposed, so therefore they have lifelong immunity. So waning immunity may occur with measles, but it's very rare. And so there is theoretically no need for adult booster vaccination, and no country in the world advises adult booster vaccination. However, because healthcare workers are in a particularly vulnerable place with repeated exposure, and also the consequences of a healthcare worker getting measles and transmitting measles onward to their patients are dire, healthcare workers may elect to have a measles booster vaccine. And this is something that would be a facility-wide decision, and it would be obviously at the discretion of the employer to arrange such a thing. But there is no recommendations of such.
Okay, thank you very much. I don't see any further questions. We also covered quite substantive information. You said your presentation can be made available.
Sure.
To whoever, yeah.
If you want to put...
we can freely share it with the participants.
Yes, I think Tando has it as well. So Tando could share it with you, and I'm very happy for it.
Yeah.
Yes, I can do that.
Okay, thank you very much. Having heard your voice once more time, I'm going to ask you to just do the closing remarks for us, the presentation this evening. And nice meeting you again, Kerry, after many years on the Days Hotel in Joseph.
Wonderful, thank you.
Sure.
Hi, Doctor. Hi, everyone. So thank you so much to the Clinics group and to Dr. McCarthy for this beautiful presentation. I hope that everyone, because I could see that there were quite a lot of people who were online, up to 76 at some point. I truly hope that this has been helpful and has raised enough awareness in the current wave of measles outbreak. That's it on my side. I thank you both. Have a great night.
Thank you, and have a good evening, colleagues. And thanks, Ekamu and the marketing team.
Thanks.
Thank you, Dr. Bila.